Yes, welcome one and all. Hello and good day. Good day to one and all present here. Let me introduce myself, Sarah, representing the Innovation United States of America, Mississippi. I'm going to moderate today's sessions on behalf of organizing committee members. I'm excited to open the virtual session day 2 of the conference, 13th World Conference on Cardiology and Diabetes Endocrinology, which is being organized by NASA and scientific meetings. Let's now begin the oral sessions for today's conference. Let me welcome our first oral session presenter, Selva Sundari S. from Wells Institute of Science, Technology and Advanced Studies, India, to present her research work on translation endocrinology of integrative lifestyle therapy, modulation of hepatic and glycemic biomarkers in women with metabolic dysfunction, associated steatotic liver diseases, evidence from a pilot randomized controlled trial.
Good afternoon.
Yes, very good afternoon, Selva Sundari. Please start your presentation and welcome to the conference.
Thank you, ma'am. Good afternoon, respected chairpersons, renowned experts, and fellow researchers. It is my privilege to present at this International Forum on Endocrinology and Metabolic Health. I am Selva Sundari, research scholar from the Department of Yoga at Wales Institute of Science, Technology and Advanced Studies, Chennai, India. Today, I will be presenting my study titled Translational Endocrinology of Integrative Lifestyle Therapy in Women with MASLD. That is Metabolic Dysfunction Associated Steatotic Liver Disease, or otherwise called MASLD. It is no longer just a hepatic condition. It represents a systematic endocrine disorder driven by insulin resistance and metabolic dysregulation. Despite its rising global burden, effective, scalable, and mechanism-based interventions remain limited, particularly in women. In this context, my study explores whether integrative lifestyle therapy combining yoga and dietary modification can modulate key endocrine pathways and translate into measurable improvements in hepatic and metabolic biomarkers. Metabolic dysfunction associated fatty liver disease, previously called as NAFLD, that is non-alcoholic fatty liver disease. It is the accumulation of fat cells in the liver cells in the absence of alcohol. It is mainly due to the metabolic dysfunction. It is now recognized as a major global metabolic disorder. Its prevalence is increasing due to sedentary lifestyle, refined carbohydrate consumption, obesity, and insulin resistance. MAFLD is strongly associated with metabolic syndrome, type 2 diabetes, and cardiovascular disease. These metabolic disturbances lead to excess fat accumulation in hepatocytes, that is liver cells, resulting in hepatic steatosis. Epidemiological studies indicates that fatty liver disease is highly prevalent in individuals with metabolic disorders. Approximately 70 to 80% of individuals with obesity develop fatty liver. Nearly 90% of patients with insulin resistance or type 2 diabetes shows hepatic fat accumulation. And pathophysiologically, insulin resistance increases lipolysis, that is breakdown of the stored fat in the adipose tissue. leading to elevated free fatty acid reflux in the liver. This promotes hepatic triglyceride accumulation and steatosis, which can trigger oxidative stress and inflammatory pathways, eventually progressing to liver injury and fibrosis. Therefore, early lifestyle intervention are essential to prevent the early progression of the MASLD. As highlighted in this slide, global burden of liver disease 2023 updates nearly 1 billion people are affected globally, and 29.1% middle-aged women from a significant proportion of cases. Despite this growing burden, most studies focus on yoga alone or diet alone. The combined effect remains underexplored. There is limited research linking endocrine mechanisms to clinical outcomes. So this clearly identifies the research gap. Aim of the study. Aim of this study was to evaluate the effects of yoga, dietary modification, and their combination on ALT, that is alanine aminotransferase, which represents hepatic cellular injury. And triglyceride. The second variable is triglycerides, which represents dysregulated lipid metabolism. And third variable is fasting blood glucose, which represents a surrogate marker for insulin resistance. Additionally, we aim to explore whether these interventions can modulate underlying endocrine mechanisms, particularly insulin resistance. Methodology of our study is followed a pre and post interventional clinical design. Yes, a total of 21 middle-aged female participants aged 40 to 50 years diagnosed with grade 1 and grade 2 fatty liver with the USG were included. Participants were divided into 3 groups: yoga only group, diet only group, and combined yoga and diet group. Each group consisted of 6 participants. The intervention lasted 8 weeks with 6 days per week. Pre and post assessment included ALT, triglyceride, and fasting blood glucose, as mentioned earlier. Yoga intervention included preparatory practices, asanas, pranayama, and relaxation techniques. Biomechanical and physiological analysis of these selected asanas, such as Trikonasana, Ardha Machendrasana, or Bhujangasana, or involves lateral flexion, spinal rotation, and extension, which creates mechanical compression and stretching of abdominal organs. This may enhance hepatic blood circulation, portal venous flow, and metabolic activity, contributing to improved liver function. The dietary intervention included high fiber diet, reduced refined carbohydrates, and caloric regulation. The combined group followed both protocols, aiming for a synergistic metabolic effect. The dietary intervention followed ICMR and NIN dietary guidelines, that is, Indian Council for Medical Research and National Institute of Nutrition dietary guidelines for Indians, focusing on balanced nutrition and caloric regulation. This slide illustrates the translational endocrinology framework underlying our study. MASLD begins with endocrine dysregulations, particularly insulin resistance, hyperglycemia, and elevated cortisol. Through these integrative intervention, yoga promotes autonomic regulation and stress regulation, while diet supports metabolic regulation and caloric control. These interventions lead to biological modulation, including improved insulin sensitivity, reduced hepatic gluconeogenesis, and reduced hepatic lipogenesis. In MASLD, increased lipogenesis, which is fat synthesis in the liver, and reduced lipolysis, which is fat breakdown, contribute to fat accumulation. So these integrative therapy helps shifts this balance from fat storage to fat utilization. Ultimately, this results in clinical outcomes with a significant reduction in fasting blood glucose, along with improvements in ALT and triglycerides. Statistical analysis data were analyzed using ANCOVA to adjust for baseline differences Post-hoc analysis was performed using Chef's test with significance set at p-value of 0.05. Results. First, looking at ALT levels, we observed significant differences across all the groups based on ANCOVA analysis. The yoga with diet group showed the greatest reduction, indicating improved liver function. Moving to triglycerides, all three groups demonstrated a reduction. However, these changes were not statistically significant. It may be due to short duration and small sample size. We observed a statistically significant reduction in fasting blood glucose with a maximum improvement in the yoga plus diet group, as shown in the ANCOVA table. The F value indicates significant differences for ALT and glucose with p-value less than 0.05. Overall, the combined intervention consistently performed best across all parameters. The combined intervention showed the greatest improvement in glucose reduction, indicates improved insulin sensitivity. ALT and triglycerides improved, though not statistically significant. These effects are likely mediated through endocrine modulation, insulin regulation, and cortisol reduction. This supports a mechanical-based approach to MACD management. Clinical implications of this study include a cost-effective solution, a non-pharmacological approach, and a scalable intervention, especially beneficial for women and community settings. Conclusion of this study included yoga plus diet showed the best outcomes. Fasting glucose reduced significantly. ALT and triglycerides showed improving trends. The mechanism appears to be improved insulin sensitivity. This highlights the importance of targeting endocrine pathways in MASLD. Limitations of this study include small sample size, short duration, absence of control group, and limited biomarkers. Future studies should address these limitations. Final statement of this study is I would like to conclude with a statement. Integrative lifestyle therapy is not merely supportive care. It is a mechanism-based intervention targeting the endocrine roots of MASLD, that is non-alcoholic fatty liver disease. Thank you for your attention.
Yes, thank you so much, Selva Sundari. Thank you very much, Selva Sundari, for your such an informative presentation. If anyone has questions for Selva Sundari, please post them in chat or you can unmute and ask her directly to answer your queries.
There's no questions, it seems.
Yes, hello Sundari. Hope there were no questions from the listeners who are there.
Thank
So,
you, ma'am. Thank you for the wonderful opportunity. I think we have completed our time. Thank
yes, there were no worries. Yeah, once again, thank you so much for your excellent informative presentation, Selva Sundari. Next, moving forward to the next presentation from Qatar Alabed from King Fahad Military Medical Complex Hospital, Saudi Arabia, to deliver his presentation on nurses and healthcare professionals' competencies and readiness for delivering digital diabetes services in Saudi Arabia, a systemic review. Yes, please, Qatar, please start your presentation.
Hello everyone. It's nice to meet you all. I'll just try to share my screen first. Hello everyone. Is my screen clear?
Yes, it is perfect.
Um, so um, Today, I'll be presenting the nurses and healthcare professionals' competencies and readiness for delivering digital diabetes service in Saudi Arabia. So this is like a systematic review. In our country, diabetes poses significant burden on Saudi healthcare system that requiring us to do continuous monitoring and coordinated with the multidisciplinary care. Digital health services such as telemedicine, mobile application, will offer important opportunities to improve the diabetes management and patient outcome. So, um, in this in this in this slides, I will show an evidence, or in this research evidence, that there is a variable in digital literacy between the healthcare professionals. And I'm just going to focus on nurses, physicians, pharmacists, social workers, and radiology staff. Despite our national effort to strengthen the digital health, evidence on healthcare professionals' readiness for digital diabetes service in Saudi Arabia remain limited, and I will explain why. So now first I will explain the method. The method that I use in research, in my research, so the strategy is it was conducted in PubMed, Scubus, Web of Science, and Google Scholar. And I used 52 research from 2010 to 2024. My eligibility criteria included the studies examine healthcare professional competencies and readiness for digital diabetes care, involve key professional group, reported original research, and it was all in English. Two reviewers independently screened titles, abstract, and full text, and there was actually no disagreements. The data was the data on a study design, a professional group, competencies, barrier, facilitators, and training were extracted and synthesized. And then we did a mixed method of our quality assessment. And the finding, of course, was organized by a professional group and the key competency domains. The result, before the result, I'll talk about our objective during the research. So my objective were to assess the digital literacy and competency, to compare the readiness across the professional groups, to identify the barriers and facilitators, and evaluate the training and educational lead. So actually, the result out of this research, nurses mostly shown moderate digital literacy, and also even the physicians pharmacist, social worker, and radiology staff were the most ready people among all the healthcare professionals. Um, for nurses, they reported limited formal training and high workload were the key barriers, while leadership support and continuing education facilitate adoption, of course. For the physicians, the challenges mainly it was like to generate the data through the system, like if the patient's going to take their blood sugar, how to transfer those data into the medical system, and they prefer to have a certain policy so that whatever they are diagnosing and treating will be legal. For the pharmacist, it was like mostly about the telecounseling in regards to medication and explaining the reason behind the medication and how to take it and all this. They were a bit concerned about their low patient engagement since it's going to be via telemedicine. But it's the same also. Having a certain policy and training will help a lot in this matter. For the social worker, for them, they were ready, but most of the time for the social worker, it's the same. They prefer standardized digital competency framework so that they will be giving their work in a safe manner. For the radiology staff mainly they will be managing the complications from diabetes. For them, they are already dealing with imaging and AI assist for diagnosing those complications. So they were the most ready among the healthcare professionals, but also they would prefer to have certain training and policy. So my conclusion is that healthcare professionals in Saudi Arabia shows moderate to high readiness for digital diabetic care. Organizational support, interdisciplinary collaboration, continuous professional development facilitate adoption, while resistant to change or inconsistent training and lack of standardized competency framework remain the key barrier. So these findings highlight the need for national competency standards, sustain institutional support to strengthen the digital diabetes service in Saudi Arabia. Thank you so much. Any questions?
Yes, thank you so much, Kauthar Alabet, for sharing such valuable insights with us today. You're welcome to drop your questions or unmute and ask her directly to answer your queries. Yes, Kauthar. Hope there were no questions. And
Thank you so much.
yes, and once again, thank you for your informative presentation.
Thank you so much. Appreciate it.
Next, moving forward to the next presentation from Rania Alanono from Thamara Polyclinic, United Arab Emirates, to deliver her presentation on audit by Dr. Rania Alanono 2017 Incretin Drugs for Diabetes Management. Yes, I pleased to welcome Dr. Rania Alanono to deliver her presentation. Yes, Dr. Rania, please start your presentation by sharing your screen. Yes, Dr. Rania, please start your presentation. Yes, Dr. Rania, please start your presentation.
على راسك وتعالي، حطي على راسك وتعالي. لسه ما بلشت. اوكي.
Yes, Rania, your presentation slides are visible to us. Please start with your presentation.
Hi. Can you hear me?
Yes, we can.
Yeah. Okay. And can you see the screen? The presentation I shared?
Yes, your screen is visible.
Okay. ما بس شو بدي وراي منظر ايمو.
Is there any issue to start your presentation, Dr. Rania?
No problem, we can start.
Yes, we can.
Okay. Okay. Hi everyone.
Hello.
Hello.
Hello. بعدين امشي هيك. ما شايفة ما عم تطلع وقت عم بكبس عليها ما عم تقلب. Sorry, I have issue. I cannot move the presentation. So 1 second only.
Yes, Dr. Rania, can I know your consent to present?
Yes, okay. Hi, everyone. This is Dr. Rania from Abu Dhabi. I'm going now to share my some points about my practice as primary care physician treating diabetes and obesity in Abu Dhabi. So we will start. Okay. Actually, as primary care physician, every day we will see patients with diabetes, obesity, dyslipidemia, hypertension, like these cases. So in all chronic cases, we want to know that it's not only to refill the medication for chronic patients, like patient with diabetes especially. We need to ask every patient about not only medicine if he's taking regularly, but also we want to ask them if there is any cause or a reason that they stop the medicine or they are not strict to take the medicine on proper time. We need to ask about mood. We need to ask about food, about his personality, work, type of work, how things is going. And we need, very important to ask if they did blood tests regularly. We know that blood tests for diabetes patient, if it's not controlled, need to be done every 3 months. But if it's controlled, need to be done every 6 months. Also about eye tests, neurological test, cardiological test, dietitian visit, all these things we need to clear during this actually few minutes, 10 or 20 minutes while visiting us in the clinic. We need to ask about the travel history or if there is any plan for change in the lifestyle, like during Ramadan, for example. So it should be patient-centered approach. We need to listen to the patient, and we need to know his needs. So our plan is to make better diabetes management. We need not to work alone. We need to work with the whole team. You know, diabetes management, like all other chronic disease, it's multidisciplinary treated. So everyone in the clinic is involved, including the nurse, physician, dietitian, surgeon, cardiologist, ophthalmologist, dermatologist, psychiatrist, dentist, and the pharmacy also. We need to take the family history. We need to know from the first visit if there is any family history, smoking, what about the physical activity, if they have also another usually associated with hyperlipidemia, hypertension. All these things need to be clear from the first visit. All of us know that the problem with the diabetes, it's not only high blood glucose. We are all our aim. We aim to stop the complications which will affect each part of the body of patient with high blood glucose. So we need to know when it was first diagnosed. Many times we see the patient who are late diagnosed and maybe many years he was suffering from high blood glucose and he doesn't know. So we need to know the date of the diagnosis and what type of diabetes, type 1, type 2, and what the type of the therapy also, if he's taking oral or injections, and the degree of control. As I said, we need to do the lab test to know in which stage we are pre-complication or after complications. Health education is very important. We need to teach the patient about self-monitoring, because he need to know 24 hours we cannot be with the patient. Even we have now better communication, but still the patient should be educated, should be well educated. As I said, lab test is very important. And we need to know that we need cardiologist consultation yearly, at least, and ophthalmology also yearly. An annual foot examination all these things can prevent serious damage, and we need to make regular referral for surgeon, for derma if needed. How to stop complication? Blood pressure should be monitored, kidney function should be monitored, dental health and mental health. And we should not forget that vaccination is very important for chronic disease like influenza, pneumococcal vaccine, and other specific recommended vaccination. So we need to know if he is taking his regular vaccination. Actually, there is some gaps in achieving these goals. We know that there is a new medication. We will speak in more details later, but the problem with the prices, and if there is insurance, not all type of insurance will cover the medication. There is a new instrument like to check the blood glucose like Freestyle Libre. There is now more options actually to make regular checkup for the blood glucose without doing puncture for the finger. Adherence to the treatment is very important. In some cases, as during COVID, we did a lot of teleconsultation and communication with the patient in different way, face-to-face or virtual. The most important that we know that he is under continuity of care, especially when they have complication, micro or macrovascular complication. Supportive, we need to be very supportive for the patient, and we need to be in touch with them and do referral when it's needed. As I told you, it's only 10. If it's established patient, it's 10 minutes only to do the consultation. But if it's first time, it's 20 minutes. But in my opinion, it's not enough. There should be another way to keep communicating the patient. Actually, I did the clinical audit. It was 2017 when the GLP-1 was still new. My audit was, the aim of the audit was to critically evaluate our practice and to suggest real practice improvement. I did follow up for 150 patients with type 2 diabetes for 3 to 6 months in Abu Dhabi, Al Noor Hospital. They were taking incretin drugs, yani GLP-1 and DPP-4. I used 5 variables, which is HbA1c, blood glucose, blood pressure, body weight, and eGFR. The result was that only 25.8% of patients reaching the targets, which is improvement in the HbA1c, blood glucose, blood pressure, body weight, only 1/4 of patients reaching the target of the treatment. And this was not like worldwide, because the worldwide it's 54. So there was, I explored that there are gaps in our practice. So after the audit, we did some recommendation that time, which was 2017, that to develop a system which is enable easier identification and control for the diabetes, and better system to do communication for all related team in the clinic. As I told you, cardiology, ophthalmologist, pediatrist, dietitian, like this. And to emphasize on structured education. We also recommend that we need to identify criteria for routine case examination, like we do checklist in each visit to make sure that each system was examined. And we suggest to make telecare intervention from web-based system like this or mobile phone, and establish a new medication program, because GLP-1 that time was new and there is no clear program in the practice. Actually, now during the last year, from February 2025 to February 2026, I was following under same drug GLP-1 for weight management. I follow about 30 patients were randomly selected to examine the impact of GLP-1 receptor agonist on the weight loss. About 20 patient was taking Mounjaro, and the 10 others, it was Rybelsus or Ozempic. The results show that 20% they lost only 5 kg, 37% about 5 to 10 kg, and about 5 to 10% was 5 to 10 kg was 43%, and more than 10 kg, which is our aim, was only 37%. So there was good impact. The feedback from the patient was good. They were happy that they reduce weight, but not same for all patients. So again, the new approach for diabetes and obesity, it's multifactorial approach, which is summarized by A, B, C, D, E, S. We find that not only to check HbA1c, not only to check weight, we need to be multifactorial approach. So A, it's go for A1c, B for blood pressure, C for cholesterol, D for drug. We need not only to control diabetes or control the weight, we need also to protect our heart and our kidneys. We need to protect the kidney and heart for the patient, which is very important. E, it's going for education and exercise, diet, healthy body weight. Finally, S, it's for screening for complication, smoking cessation, and stress. This approach, it's actually from 2018 start we to hear from ADA, EASD, that they need to be multifactorial, and we need to make a multifactorial approach. So it's not only to check the HbA1c, not only to check the weight, we need to check the blood pressure, we need to check the blood for kidney function. There should be no, we need to do microalbuminuria to check any changes in kidney function. And we should not forget smoking, to ask about the smoking. And for sure, a blood test LDL should be, as the latest guidelines, to be less than 2.5 millimole or 97 milligram per deciliter for patients with diabetes, especially. So, as we know, all of us before was metformin, till the recently was the first only drug to start metformin as medication for diabetes. But as our approach different, now the guidelines, all of us know that not only metformin, from the first day when we diagnose diabetes, we can start with not only metformin, we can start with metformin plus SGL2 inhibitor, or metformin plus GLP-1, depends on the patient. The good news that now we have Malaffi in Abu Dhabi, which is all files are connected. So if the patient did some blood test in one clinic, we can check the result in other clinic. So no need to repeat the blood test each visit. So we can check Malaffi and take all information which is in the system, in our system. We have more advanced now digital health, better communication for long-term blood sugar. All patients now that can, as you can see, they can check blood glucose and share with the doctor, take the advice. This is good. And all we know that the guidelines recommendation for GLP-1, SGL2 now, it's very early to protect the kidney and cardiovascular complication. So as we told you, from 2018, the guidelines start to improve, and we have a new medication like inhaled insulin, and we have oral GLP-1 now recently, this month and the month before, the FDA approved Wegovy as tablet, and from Lilly also they have a new medication which will be start soon, oral tablet, those who cannot take subcutaneous. This for weight. I mean only this GLP-1 for weight, but for diabetes, it's different. The NICE guidelines, now it's clear in 2026 that the first line from the very beginning, we can start with metformin and SGL2 inhibitor, which is very important for the kidney and for the heart specifically. If the patient have cardiovascular disease, we need to start with metformin, SGL2 inhibitor, and GLP-1 receptor agonist. If there is heart failure, SGL2, it's fundamental, and it's very important. And if the obesity is okay, 1 or 2 minutes. Okay. We need to make sure that kidney function is good. As conclusion, since 2018, there was evolution in the treatment recommendation in type 2 diabetes management from the strategy as HbA1c main to only target the lower the best. We need to exclude hypo and weight gain. So as I told you, the approach ABCDES this is the new approach. Oh, okay. On slide, no problem. And the new medication is very good now. We can make each patient is a case. There is no one treatment for all the patients. Each patient should be identified and take the specific treatment for which is suitable for him. We need to know the kidney function, liver function, and start the medication depends on the case. Thank you very much.
Yes, thank you so much, Dr. Anya, for your informative and insightful presentation.
Stop. I will stop the screen. Okay, thank you.
Yes, if anyone has questions for Dr. Rania, please post them in chat box, or you can unmute and ask her directly to address your questions.
One specific question. Yeah, if anybody has a question, no problem.
Yes, Dr. Rania, hope there were no questions from audience. And once
Thank
again,
you very much.
yes, thank you very much to you for your insightful, well-prepared presentation.
Thank you. Thank you very much. My pleasure.
Yes.
Thank you. Bye-bye.
Yeah, thank you.
Thank you. Bye-bye.
Yes, moving forward to the next presentation from Jonathan Alvin Viryaputra from National Cardiovascular Center, Harapan Kita Hospital, Indonesia, to deliver his presentation on future directions in heart transplantation, innovation, integration, and possibility. Yes, Jonathan. Hi.
Hello, thank you for having me.
Shall we share your PowerPoint presentation slides? Or you can.
Okay, for now, I'm unable to share my screen. Can please the organizing committee help me to share the screen? Thank you.
Sure.
Kopi, 10.000 COD. Ya. Thank you, Bang.
Thank you very much. Good morning, everyone. My name is Jonathan. I'm from Indonesia, and now I will present the future directions in heart transplantation, which consists of innovation, integration, and also possibility. Next slide, please. Okay, so the first slide I want to show you. Wait a moment. Okay, so the first slide I want to show you is the two chest X-ray pictures. So the final atrial ECMO was actually continued after transplantation at 2 to 3 liters per minute to support the xenograph. So what I'm going to show you on the left side, the panel A, is a chest radiograph obtained before transplantation of the heart, showing there's a slight cardiomegaly. And then also the panel B on the right side shows a chest radiograph obtained after transplantation, showing the xenograph in situ. So the method is we do the transplantation and then we observe the condition of the patient 46 days after the transplantation. And then also the patient's urine output decreased actually around 8 hours after surgery, and the renal flow was re-evaluated, and endovascular stent was placed for an occlusion of an upper pole left renal artery by the false lumen of a residual dissection, which had been caused by the aortic cross clamp and had been diagnosed repaired during the transplantation procedure. However, the oligoanuric acute renal failure persisted throughout his post-operative course and led to the administration of the renal replacement therapy. The patient's trachea actually was extubated after chest closure on day 2 after transplantation. And then also the chest radiographic attached showed clear lung fields. The inotropic support was also never warranted, and the ECMO was continued on the day 4. Next slide, please. So this is the picture of the transthoracic echocardiography of the patient. Yeah, the transthoracic echocardiography of the transplanted xenograph obtained on the day 19 after transplantation. On the panel A, it's a parasternal short axis view, showed that normal xenograph function, normal global longitudinal strain, and also normal left ventricular posterior wall thickness in the end of diastole. The transthoracic echocardiography also performed on the day 49th on the panel B on the right side before the cannulation for veno-arterial extracorporeal membrane oxygenation or ECMO showed preserved systolic function, less negative global longitudinal strain, and slightly increased thickness of the left ventricular posterior wall in the end diastole. Next slide, please. Okay, so this is the clinical details and also some test results during the postoperative courses. So in short, the mean fluorescence intensity values were normalized to positive control, a sign of a value of 100%. And then also global longitudinal strain is expressed in panel B as the absolute value. Strain is typically reported as a negative percentage. GCSF denotes granulocyte colony stimulating factor, IVFG, and then also LVEF. Next slide, please. So this is the picture of histologic assessments. Yeah, the first endomyocardial biopsy on the panel A, which obtained the day 34th after transplantation, showed actually normal histology characteristic. The second endomyocardial biopsy, the panel B, on the day 50th, showed interstitial red cell extravasation, fragmentation, and edema without cellular infiltrate or intravascular thrombosis. The third endomyocardial biopsy on panel C, day 56, showed some resolution of interstitial edema and red cell extravasation, but also showed evidence of necrotic myocytes. The septum at autopsy, the panel D and E on the day 60, showed interstitial edema and red cell extravasation, myocardial necrosis, scan fibrosis, and also central nuclei. So on the day 34 after transplantation, an endomyocardial biopsy showed no evidence of rejection actually. And the heart had a right arterial pressure of 5 millimeter Hg, the pulmonary artery pressure around 25 per 15 millimeter Hg, a cardiac index, the cardiac output in the liters per minute divided by the body surface area in square meters of around 2.7, and also a mixed venous saturation of 65%, which hemoglobin level is around 8.1 gram per deciliters. The patient was able to rehabilitate without any cardiovascular support, and the sonograph function normally without evidence of rejections. Next slide, please. Okay, so this is the coaxial three-dimensional printing-enabled precise multimaterial deposition, demonstrating the strong potential across the diverse field, yeah, actually, including industrial monitoring, health sensing, AI hardware, and also food packaging. Its core value is prominently realized in the biomedical domain, where it has revolutionized tissue engineering. Yeah. The present review consolidates advancement in 3D coaxial bioprinting across diverse biomedical applications, focusing on its transformative potential in vascularized tissue engineering, spatiotemporal drug delivery, and also the patient-specific disease modeling. This review was also explored unresolved challenges such as bioink optimization, and also the most importantly, functional vascularization, yeah, while proposing integrative solution that combine coaxial printing with AI and also hybrid fabrication strategies. Next slide, please. Okay, so a total of around 1,238 TAVR patients were performed from 2016 and also to 2024. The frequency of TAVR explants increase every year actually, from 34 performed in 2016 to 272 performed in 2023. The last year of reported data, as you can see on the figure number 2, the median number of TAVR explants performed per hospital was 2 of the 300 and around 375 hospitals that perform at least one TAVR explant. 234, around 63%, perform less than 3 TAVR explants, and around 150 or 40% only perform one TAVR explant, and another 165, around 44%, only perform at least one TAVR explant in 1 year. Of the 707 surgeons who perform at least one TAVR explant, 444 or around 63% only perform one TAVR explant. As you can see here, the implication is actually the first one. The annual TAVR explant volume is increasing in the United States, And then number two, TFER explant is highly concentrated at a small number of hospitals. Number three, while an initial volume outcome relationship was present between hospital TFR explant volume and also TFR explant 30-day mortality, recent data shows no relationship at all. And then lastly, the TFR explant will likely become fundamental surgery for many cardiosurgeons. Next slide, please. So this is the multivariable analysis of the overall study cohort from 2016 to 2024, demonstrated that congestive heart failure, concomitant mitral valve surgery, and also concomitant CABG procedure, concomitant aortic surgery, and female sex were associated with increased odds of 30-day mortality following TFR explant. High volume hospital status was not associated with 30-day mortality following TFR explant. Okay, so this is my last slide. Thank you for the time and thank you for the opportunity.
Yes, thank you so much, Jonathan Alvin Viryaputra, for your informative and insightful presentation. If anyone has questions for Jonathan, please post them in chat box or you can directly ask him. Yes, Jonathan. Hope there were no questions.
Okay, thank you so much, organizing committee, for having me. Thank you for the time and opportunity.
Thank you. Thank you so much for your presentation. Next, I would like to call upon Mohammed Shriban from East Suffolk and North Essex NHS Foundation Trust, Cardiology, Colchester, United Kingdom, to deliver his presentation on evaluating the impact of heart failure therapy in patients with atrial fibrillation, atrial flutter, and liver dysfunction undergoing electrical cardioversion.
Yes, hi, Jenny. Hi, conference organizers. Thank you for having me today to present my abstract, my research-based abstract in the conference today. So I will try to share my slides. Can you see the slides on the screen clearly?
Yes,
Okay, so shall I start then?
yes, please start your presentation.
Okay. So my name is Mohammed Shekiban. I am working as an acute medicine registrar with a special interest in cardiology and electrophysiology, working in East Suffolk, North Essex NHS Foundation Trust in Colchester, Essex in the United Kingdom. So this is a research-based abstract named as evaluating the impact of heart failure therapy in patients with atrial fibrillation slash atrial flutter and left ventricular dysfunction undergoing electrical cardioversion. The authors is myself as the main author and my colleague who is a ST5 cardiology registrar, Dr. Sapi This abstract has been accepted as a poster presentation in the British Cardiovascular Society annual conference, named as the Risk Business in Manchester, United Kingdom, from the 2nd to the 4th of June 2025. And it has been published in the peer-reviewed heartbmj.com, which is a PubMed and Midline cited journal. It was first published on 13th of August 2025, and online issue published the same dates exactly. And just to confirm again, there is no conflict of interests. So before going to the to discuss the abstract, I will just give a quick introduction on atrial fibrillation, because this is the main component why the abstract is based on. Is about management of rhythm management of atrial fibrillation. So atrial fibrillation, as we all know, is considered the most common sustained arrhythmia seen in the practice. It's characterized by disorganized, uncoordinated, and ineffective atrial activity and contraction. As we can see in the practice here in the UK, and I will expect as worldwide, there is an incredible increment in the incidence and the prevalence of atrial fibrillation. Lifetime risk after 40 years in the UK is considered as 25%, and 10 to 20% of the people aged above 80 years in the UK have established atrial fibrillation. The complications of atrial fibrillation, it's of course a big burden, a big health problem here in the UK. Apart from the increasing incidence and the symptoms burden and quality of life impedance, the most significant cardiovascular complications of atrial fibrillation include hemodynamic instability, thromboembolic events, and increased risk of VTE such as stroke or other embolic complications. Cardiomyopathy as well, due to long-standing AF with atrial remodeling and left ventricular dysfunction, and also heart failure as well. So the core principles of the abstract is that heart failure is a very, very important key determinant in the prognosis in patients with AF. So we all know that AF is very common, and in essence, it doesn't pose significant complication by itself, and it can be managed properly as by rate control or rhythm control. But the problem is patients who have, concomitant heart failure and with AF, this significant, implies a very, very important association and can play a very significant role in the patient's prognosis. So Birmingham cohort showed that 57% of those patients with new heart failure have concomitant atrial fibrillation, and also 37% of those patients with new diagnosis of AF, either new AF or even later on with persistent or paroxysmal AF, have concomitant heart failure as well. So as we can see, the development of heart failure in the patients with atrial fibrillation, studies have shown that both of them can be associated. So heart failure with atrial fibrillation can increase the stroke and the thromboembolic events by twofolds, even after anticoagulation, and a 25% higher all-cause mortality. So this really highlights the significant contribution of heart failure in the prognosis of the patients with atrial fibrillation. The mortality rate is also highest in combination of atrial fibrillation and heart failure with reduced ejection fraction, as compared with heart failure with preserved ejection fraction. However, the rate of the VTE and the incidence of hospitalization is considered the same in both cohorts, either with reduced ejection fraction or preserved ejection fraction. as maintenance of sinus rhythm is a very important part in management of those patients with AF. Proper management of heart failure is also very crucial to avoid adverse complications, and this is the essence of the abstract and the study that we have conducted in our hospital, just to see if proper management of heart failure with patients with AF can play a role in maintaining. We just focused on the part of maintaining sinus rhythm after cardioversion. So I will just go straight forward to discuss the abstract or the paper. So the background is we are studying the patients with persistent atrial fibrillation slash atrial flutter who have undergone elective electrical cardioversion. And those patients have also concomitant heart failure with reduced ejection fraction. So the essence of the study is how managing the heart failure on those patients with AF who underwent electrical cardioversion. Does this have an impact on maintaining the sinus rhythm after cardioversion or not? So the studies have shown that the patients with impaired LV function have poorer chances of sinus rhythm maintenance post-electrical cardioversion. So to better understand the role of certain heart failure therapies, so heart failure management here, we only focused on the medical treatment with prognostic medications and also the long-term follow-up by the heart failure team in the community, and how both are have any effect on maintaining the sinus rhythm on those cohort of patients. We have not included the certain aspects of heart failure treatment, such as cardiac resynchronization therapy, for instance. We just focused on the medical management and the community follow-ups. So the methods that we used in this study, that it's a single center retrospective study we conducted in our district general hospital from in a period of 5 years, from 2019 to 2024. We have studied those patients to assess the outcome of heart failure management. So we included the patients with persistent AF and atrial flutter undergoing elective electrical cardioversion with varying degrees of LV dysfunction. So we divided them into patients with reduced ejection heart failure with mild reduced ejection fraction, in which the EF is 40 to 50%, and patients with reduced heart failure with reduced ejection fraction with EF is less than 40%. And this is based on the most recent thoracic echograms that was conducted on those patients just prior to the scheduled elective cardioversion. It's important to stress that some of those patients with heart failure reduced ejection fraction have previously diagnosed with heart failure before the study, so they have previous transthoracic echoes with established congestive cardiac failure, and those are included in the studies as well. We included all the patients aged more than 18 years with persistent AF and atrial flutter as well, who underwent the elective cardioversion in the period between January 2019 and January 2024. And they were followed up after cardioversion up to 6 to 8 weeks post elective cardioversion, and they are assessed with an ECG to whether the sinus rhythm was maintained or not. So the results. So the total number of patients who with persistent AF and atrial flutter who underwent elective cardioversion in this period were 176 patients. So we include the patients who had heart failure with reduced ejection fraction were 50 patients, and those who had heart failure with mild reduced ejection fraction were 38. And the rest of the patients were diagnosed with heart failure with preserved ejection fraction. They were not included in the study. So the proportion who were the proportion of the patients with heart failure with reduced ejection fraction, who are 50 patients who were under direct follow-up by the heart failure nurses in the community was 58%. And the proportion of the 38 patients with heart failure and mild reduced ejection fraction who were under direct heart failure nurse follow-up in the community were only 18.4% respectively. So we found that the association between the regular community heart failure nurse follow-up and maintenance of sinus rhythm post ECV was not significant in each cohort of patients with heart failure. However, the association was significant in the cohort of patients with prior diagnosis of CCF that I just mentioned earlier, that we actually included them, that who have previous echoes and have been having long-standing congestive cardiac failure. And the study has shown that the patients who have regular visits by the heart failure nurse and they have compliance with heart failure visits in the heart failure clinic follow-up in the community have better chances of maintaining sinus rhythm. Additionally, in patients with ejection fraction less than 40% or patients with heart failure with reduced the patients with heart failure and mildly reduced ejection fraction, there was a significant association between them being on the prognostic medications and the chances of sinus rhythm maintenance post ECV. So regarding we found out that the prognostic heart failure medications and the good compliance and adherence on them play an important role in maintaining the sinus rhythm after cardioversion. Of the prognostic medications, and interestingly, we found out that MRAs or mineralocorticoid receptor antagonists such as spironolactone and eplerenone were significantly associated with increased chances of sinus rhythm maintenance in both cohorts of heart failure, with a binary logistic regression is P no bind no 005 and no bind no 26. Whereas the use of the other prognostic heart failure medications like beta blockers or ACE inhibitors or ARPs or SGLT2s or sacubitril and valsartan or Entresto in each cohort of patients was not associated with good chances of sinus rhythm maintenance post cardioversion. So my conclusion is, of course, this was a modest sample size in the study, but our findings suggest that patients with appropriately managed heart failure have more improved chances of sinus rhythm maintenance than patients with poorly managed heart failure. Other similar studies with the large cohorts are recommended because our cohort is only 178 patients. So I think more larger cohorts can be included in further future studies to reaffirm our findings. So our results can be applied in the community to ensure that these patients are provided more regular community heart failure nurse follow-up, allowing optimization of their heart failure prognostic medication and augment their heart failure status. And this has a potential to reduce the burden. So the advantages of that is with patients with properly managed heart failure and higher chances of sinus rhythm maintenance post cardioversion, they have better chances of reducing the burden of repeated elective cardioversion procedures and also reduced chances of unnecessary referrals to tertiary centers for AF for other invasive procedures of managing AF such as AF ablation. So in terms of critical analysis of this study, so the pros or the learning points that I can gather from it, that the study has actually focused on important correlations in cardiology practice, which are in AF and heart failure, and the impact of rhythm management and the presence of heart failure in patients with AF or atrial flutter. So the study highlights the crucial role of community heart failure team follow-up and their participation as a vital asset in overall care of patients with not only heart failure, but also heart failure with other issues such as atrial fibrillation or atrial flutter. And this study ascertains another aspect of the beneficial role of some of the heart failure prognostic medications, such as mineralocorticoid antagonists, because usually this group of medications can be sometimes missed or not appropriately prescribed for patients with heart failure, either genuine heart failure due to ischemic heart disease or like other causes such as cardiomyopathy. So this stresses the importance of this group of heart failure medications, not only because of its genuine diuretic effect, but also because it plays an important role in something hidden in the back, such as maintaining sinus rhythm for patients with AF who had cardioversion. And the study also highlights the potential to reduce the burden of repeated cardioversion, because, as I said, successful cardioversion and maintenance of the sinus rhythm of those patients can reduce the burden of repeated elective cardioversions with appointments and referrals for AF ablation. The cons of this study, which I just it can be we are looking into, and it can be improved in future cohorts, that the sample size was relatively a bit modest with 178 patients included. We have not included patients with heart failure with preserved ejection fraction in this study, despite being them a significant number of patients with heart failure and AF. Also, one of the other aspects and the cons of this study is that the window of follow-up of those patients post ECV was a bit short, so they have only followed up like 6 to 8 weeks post successful cardioversion, and there was no follow-up study for them after this, so there is no point, there is no point of ascertain if the normal sinus rhythm maintenance has been liable to be sustained on the long run or not. And again, this has the maintenance of the sinus rhythm is only based on an ECG, 12-lead ECG, rather than just like more sustained ways of detecting the underlying rhythm, such as like 24 hours, 72 hours Holter, or even an ILR. One other interesting aspect, because there is a bit of similarities between our study and the RACE-3 trial study in the US that has been published in the USA in August 2017. So the RACE-3 trial was actually focused on not only heart failure, but the other risk factors in patients with atrial fibrillation, such as hypertension, type 2 diabetes, and hypercholesterolemia. And the core focus of the study in RACE-3 trial was whether proper management of and targeted treatment of those underlying risk factors in patients with AF has a role in maintaining sinus rhythm after cardioversion or not. Of course, it's just in a short phrases, there was a significant association between proper management of the underlying risk factors on those patients and the better chances of maintaining sinus rhythm as well, with a 75% more chances of maintaining sinus rhythm compared to only 63% of better chance of maintaining sinus rhythm with patients of less controlled risk factors. So the main differences between both studies, that our studies included only patients with it was a bit broader, included patients with persistent AF and atrial flutter, and the race 3 trial just included only patients with persistent AF. Our study was focused on management of heart failure, attaining sinus rhythm maintenance in patients with heart failure and AF. Race 3 was focused on management of the underlying conditions, not heart failure, the underlying risk factors, in maintaining sinus rhythm after elective cardioversion. In our study, patients with heart failure and preserved ejection fraction unfortunately was not included, but in the race 3 trial, they included all patients with heart failure, including patients with heart failure and preserved ejection fraction. In our post-ECV follow-up in our patients, the window of follow-up was only 6 to 8 weeks in the heart failure clinic. And the point of asserting if the maintained sinus rhythm or not, it was based on a 12-lead ECG. But in the race 3 trial in the USA, they had the longer period window follow-up of those patients. It was after 1 year, and with a more specific way of ascertaining that the successfully achieved a normal sinus rhythm by broader follow-up of their rhythm through a 7-day Holter record. So this is the references, and this is the DOE link for our study, which is published online on the PubMed and Heart BMJ. And this is the last slide, and thank you very much.
Yes, thank you so much, Mohammed Shiban, for your delivering such a comprehensive and enlightening presentation. Participants are encouraged to share their questions in the chat box, or you can directly unmute and engage with Mohammed Shiban for addressing your questions.
Happy to take any questions from the participants.
Yes, Mohammed Shiban. Hope there were no questions from the participants. And once again, thank you so much for your informative presentation. It is well wonderful and appreciated.
You're welcome. Thank you very much. It has been a pleasure to present today. Thank you very much, and have a nice day.
Yes, moving forward to the next presentation from Marco Picce from San Bartolo Hospital, Italy, to deliver his presentation on extracorporeal membrane oxygenation, a life-saving procedures for patients with severe heart failure and or respiratory distress syndrome.
Hello, everybody. Can you see the screen?
Yes.
Can you see the screen? The presentation is clearly visible. Can you see the PowerPoint?
No, Dr. Markovic.
Okay. Can you see now the PowerPoint? Can you see it?
Yes, it is perfect now.
It's better? Okay. So, good morning, everybody. My name is Marco Picciche. I'm cardiac surgeon. And this presentation deals with the extracorporeal membrane oxygenation. We will see the anatomy, configurations, pathophysiology, indications, contraindications, some special features, complications, and some criteria for winning and the conclusion. So what is ECMO, extracorporeal membrane oxygenation? Is a circulatory support for temporary replacement of the function of the heart or lungs. It was invented in 1971. It was implanted for the first time in an adult patient, but at that time, mortality rate was 90%. 3 years later, Robert Bartlett implanted ECMO in a pediatric patients suffering from respiratory failure that we see in this image. And the name of this lady was Esperanza, given by the nurses. We see her 20 years later. So this operation was successful. Anyway, the early application of this technology was plagued by high complication rates and with no proven survival advantage over conventional management. But in the last 2 decades, some advances in extracorporeal technology have favorably altered its risk-benefit profile. So after the CESAR trial, which clearly showed an improvement in the death rate and that's severe disability 6 months after randomization of patients with severe respiratory failure, there has been a revival of this technology. Which is the operating principle? The basic operating principle behind ECMO is that a portion of the patient's blood is removed from the intravascular space. Blood passes through a circuit which provides oxygen and removes carbon dioxide, and then it returns back to the bloodstream. Let's see the components. There are 7 main components of an ECMO circuit, which are the console, the oxygenator, the centrifugal pump, the warmer, the blender, the access cannula, and the return cannula. The drainage cannula is called the venous cannula, allows blood to flow to the pump and to the oxygenator, while the return cannula is the arterial cannula, which returns blood from the oxygenator to the patient. So you can see here, this is in the vein, there is the drainage cannula, and in the artery, there is the arterial or return cannula. These are 2 examples of venous cannula, which usually range between 19 and 28 French. And this is an example of return or arterial cannula, which range generally between 16 and 20 French. They can be inserted with the surgical technique or with the percutaneous technique using the Seldinger technique. You can see the Seldinger technique is very well known. There is a needle, a guide wire inserted into the needle is removed, and then you remain with the guide wire and you insert the dilators and then the cannula. A special cannula is the dual lumen cannula, which is used in pediatric patients, and it is a cannula that we can see here. There is a hole in this portion which through which blood goes to the right ventricle and then to the pulmonary artery. And there are holes here and holes here draining blood from the superior vena cava and the inferior vena cava. So this blood goes to the oxygenator and then it comes back. So this avoids the femoral cannula. And this is used in pediatric patients for respiratory failure. Another important component is the oxygenator, which is between the drainage cannula and the return cannula. The oxygenator uses the principle of magnetic levitation, which we see in some train in China or Japan, like the maglev. So there is a magnetic suspension, is a method by which an object is suspended with no support other than magnetic field. And the magnetic force is used to counteract the effects of the gravitational force and other forces. This is the anatomy of the centrifugal pump. There is a rotating configuration of blades called an impeller, which is coupled magnetically to a motor. And the blades spin fast, and according to the principle of magnetic levitation, this creates a vortex which drives blood through the circuit. Well, the rotation is set at a constant rate, so the rate that blood travels through the pump is continuous and not pulsatile, like in cardiopulmonary bypass, and the pump speed is in revolution per minute. The typical pump speed are about 2,000 and 6,000 revolution per minute. When a pump speed is higher than 4,500 revolution per minute, this is usually associated with hemolysis. So the flow through the pump depends on three things: the pump speed, the blood volume available, and the downstream resistance. So the pump speed, because the higher the speed, the more flow through the pump. The blood volume available, because this can be thought of as preload. The more blood available to the pump, the higher the flow it can achieve. And then the downstream resistance. This can be thought of as the afterload. The more resistance the pump is facing, the less flow the pump can achieve. Then we have the oxygenator. The oxygenator is a large, thin membrane made of a polymer, which allows gas to diffuse across it. And the principle is this one. We have venous blood comes to the oxygenator. There is a membrane. CO2 is exchanged, and on this side, O2 is exchanged on the other side. And then it goes into the return cannula. High flow, the oxygenation depends on the flow, because higher flow from the blender allows more blood to be oxygenated. The VO2, because increasing the VO2 achieves a higher partial pressure of oxygen. And the membrane integrity, of course, because if there is something present on the membrane, such as blood clots, the diffusion, it impairs the diffusion, and the oxygenation will decrease. As well, carbon dioxide removal depends on the sweep, because higher sweep speeds results in higher CO2 removal, and the presence of water vapor in the membrane, which can impede CO2 removal. Then we have the blender, also called the sweeper. This is a device which provides oxygen to the oxygenator, and the desired fraction of oxygen is programmed and varies from 21 to 100%. You can see here, this is the blender, but this also allows the CO2 removal. The oxygenation does not depend on the sweeper, but of course, if the sweep is set to zero, then no gas will enter the membrane and no oxygenation will occur. In general, above 1 liter per meter, changing the sweep across a wide range does not affect oxygenation. It is important that you must never set the sweep to zero in a venous arterial ECMO, because this can be a life-threatening condition. And then we have the flow meter. The flow meter are the systems which are usually placed on the arterial cannula. The arrow on the flow meter correspond to the directions of blood flow. And the flow through the lines is measured by a flow meter which clips directly onto the line. So the function of this flow meter is to avoid mistake of direction. And we have also an intercooler which help us to keep the temperature we like. It is maybe very important in patients after they were found in the river or in lakes with very, very low temperature. So they are usually rewarmed with this technique if other methods, non-invasive methods, are failing. There are several configurations of ECMO. We have a VA, which means veno arterial ECMO. VV means veno venous ECMO. VAV means veno arteriovenous ECMO. BVA means veno-venous arterial ECMO, and BAA means veno-arterial arterial ECMO. The main configuration is veno-arterial ECMO, which is used in cardiogenic shock due to cardiac failure, which is mostly used in acute coronary syndrome, cardiac arrhythmic storm, or refractory to other measures, sepsis with profound cardiac depressions, myocarditis, some cases pulmonary embolism, or can be seen in cardiac surgery post-cardiotomy due to inability to wean from cardiopulmonary bypass after cardiac surgery, or post-heart transplant for primary graft failure after heart transplant. The configurations of biarterial ECMO, in the ECMO circuit is connected in parallel with the heart and the lung, and blood going through the ECMO circuit bypass the heart and the lung. This configuration is a peripheral configuration. You can see that the cannula are inserted in the arterial artery and in the femoral vein. This is the position of the drainage cannula. We can see also this in this chest X-ray. This is the venous cannula in a patient which has clearly respiratory problems. This is another position of the cannula. To my opinion, this is the best. This is the best, usually considered the best position when the tip is not at the level of the Eustachian valve, but it is across the right atrium and goes just at the beginning of the junction between the superior vena cava and the right atrium. And also laterally there are holes, so blood can goes inside. And this is a percutaneous, as you can see, femoral configuration. What you see here is the return. This is the perfusion for the leg. The problem is that when you use the femoral cannula in the femoral artery, then the blood flow in the leg is impaired. So to avoid this, you have to connect this smaller line to the arterial cannula, and then there is a 5 or 6 French small cannula which is inserted into the distal femoral artery to perfuse the leg. In this case, you have the same veno-arteriovenous ECMO, but with a surgical incision. Also, in this case, you can see the cannula which serves to reperfuse the femoral artery. The blood from these two parallel circulation will mix somewhere in the aorta, and the relative contribution to systemic oxygenation delivery is a function of how much flow is going through each circulation. If gas exchange at the patient's lung are impaired, then the oxygenated blood will mix with the oxygenated blood from the ECMO circuit, and tissue hypoxia can occur. I will tell you this will be better in the next slides. There are some territories that are vulnerable to hypoxia, and those with blood supply from the proximal aorta, which has the coronary arteries, the nominate artery, and the left common carotid artery. And these may cause sometimes the Harlequin syndrome. What does it mean? It means that when the heart is not completely stopped, it is in heart failure, but it's not completely stopped, and it has a little function. It happens that a little amount of blood goes into the lungs from the heart. And if the lungs are not perfect, it happens that some deoxygenated blood is in the upper aorta. So you can have a different circulation. So we can have a patient which is less oxygenated in the upper part and better oxygenated in the down part of the body, because there is the blood coming from the femoral artery, which is called the Harlequin syndrome. So you can see also here, in this case, we have a patient who is started to beating by itself, but there is the cannula from the ECMO, which brings oxygenated blood. So the contraction allows to perfuse the coronary artery with blood oxygenated by the lungs, but not elsewhere. So the less oxygenated areas are the myocardial areas. And this is a paradox of ECMO. In this case, when the paradoxically, when the heart activity is completely stopped, the arterial cannula perfuse everything, also the coronary arteries. From a physiopathological point of view, what happens is that there is an increase of the end diastolic pressure, because with the blood coming from the femoral cannula, you have an increase in the afterload, and so the end diastolic pressure increases. There is a stagnation, and you can have also some the formation of some thrombi. So this reveals in an increase in the left atrial pressure, and then of the pulmonary pressure and the pulmonary artery pressure and of the wedge pressure. By contrast, there is a decongestion at the level of the liver, the kidney, the spleen, with a decrease of the PVC. This is another configuration of an arterial ECMO. When you use the cannula into the axillary artery, you can use it directly into the artery or through the interposition of a graft. Then we have a veno arterial ECMO from in the central position, which we use in case of failure of cardiac surgery, when there is a difficulty in weaning from cardiopulmonary bypass. So you use a veno arterial ECMO as a post-cardiotomy. You usually put the arterial cannula, you use the same cannula you use in the operation in the aorta and the cannula of the right atrium. And this is how a patient looks when he goes out from the operating room without weaning from cardiopulmonary bypass, and so you need to connect the patient to an ECMO. In this case, you have also drained, reduced the overload of the left ventricle with a cannula in the pulmonary vein. It is sometimes necessary to bend the heart to decompress the left ventricle and to avoid the distensions. You do that when the aortic valve does not open at all, or when there is a severe aortic regurgitation, or when you have severe refractory pulmonary edema secondary to left ventricle overload. These are the main indications. You can decompress the heart in these several ways, with the cannula through the apex of the heart, like in this case through a left thoracotomy, or through the right superior pulmonary vein to the left atrium or to the pulmonary artery. And there are also some percutaneous ways to decompress: transaortic vent, transeptal vent, transpulmonary vent, or with the impella, or with the intra-aortic balloon pump. The intra-aortic balloon pump is a well-known method of assist device, which usually increases the perfusion of the coronary artery and decreases the afterload. Venous ECMO is another configuration. You use venous ECMO when you have a patient with respiratory failure. In this case, you have the cannulation. The cannulas are inserted not in the arterial stream, but in the venous stream, which are the jugular vein, the right jugular vein, and the right femoral vein. And the blood goes to the oxygenated blood goes through the jugular vein into the right ventricle and then to the lung. As you can see here, this is a patient clearly with an impairment of the respiratory condition. You can see there are two cannulas. This is the cannula into the jugular vein and the cannula that comes from the femoral vein. And these are two next. This is not the correct position, because they are so-called the kissing cannulas. This is a wrong position. They must be distant at least 10 centimeters. Otherwise, you risk that the oxygenated blood coming from the superior cannula is sucked by the drainage cannula, and it does not go through the circulation. You can see the same mistake of position also here. This is another case of kissing cannulas. You see the superior cannula and the inferior femoral vein cannula, and the distance is less than 10 centimeters. So the blood from here, instead of going into the heart, is sucked directly into the drainage, venous drainage. The indications for venous ECMO are mainly acute respiratory distress syndrome, or we used a lot during the COVID pandemic, but also during the H1N1 pandemic infection. And we use it with the bacterial or viral pneumonia, aspiration syndrome, or we can use as after lung transplant as a primary graft failure after lung transplantation. And this is a report, the first Italian report on the use of venous ECMO in patients with respiratory distress syndrome due to COVID-19 infections. I lead this work. This is the first Italian multicentric study. I enrolled 12 centers and 71 patients, and we see that during the first wave of ECMO of COVID, we had 36% of survival. So roughly 2 patients over 3 died during the first assault, while in the last assault, in the third wave of ECMO, the ratio was inverted. There are some contraindications to venous arterial and to venous ECMO. Absolute are the uncoverable hurt and not a candidate for transplant or destination therapy, disseminated malignancy, brain injury, so a patient with a severe hemorrhage is certainly a contraindications, or also unwitnessed cardiac arrest, because you don't put the patient, you don't put in the ECMO in a patient who is almost died already, so you consider that death. And also for some cases of peripheral disease. Let's go ahead. There are some indications of veno-arteriovenous, veno-venous, and veno-arterioarterial ECMO. Peripheral cannulation may be complicated by persistent low cardiac output syndrome in case of venous cannulations, or by differential hypoxia, and in case of veno-arterial cannulation, and severe impairment of pulmonary function associated with cardiac recovery. So it means that in this configuration, actually, you move from a veno-arterial configuration or from a venous configuration by adding a new cannula, which can be added in the venous bloodstream or in the arterial bloodstreams, depending on the situations. If you have difficulty of drainage, you can use, for instance, if you have a peripheral venous arterial ECMO, you can have difficulty and you find that you have difficulty of draining, you can use a second cannula. You add the venous cannula to increase drainage in the superior vena cava, and you connect it with a Y connector, to the venous drainage. So there are some special features. Important is to verify the cannula position with X-ray, transthoracic echocardiography, or transesophageal echocardiography. It is important to keep this patient with some level of anticoagulation. It is better to use the PTT instead of the ACT, and the range of PTT should be between 50 and 60 seconds. Chatter. The chatter is another aspect we should consider, because when you see chattering, which means a vibration this way of the venous line, this means that the patient is empty or there is a drainage problem. So usually you must increase the volume in the patient, or if in spite of that chattering is still going on, there is it means that there is a malposition of the cannula. To measure measurements of blood pressure, it's better to use the right radial artery in venous arterial ECMO, because it's an equilibrium between the blood coming from the heart and that from the ECMO. While in venous ECMO, you manage the patient from an hemodynamic point of view, like all patients, because this is nothing to wait to see if the heart in this patient is functioning well. It is important to check the aortic valve, because if the patient heart cannot generate the force required to overcome the afterload, then the aortic valve will never open. But this means that if the aortic valve does not open, it means that the heart is in critical conditions. Of course, you must see the volume status of the patient. If you see if there is chattering, but you use the transesophageal or transthoracic echocardiography for that, because the central venous pressure does not really reflect the fluid responsiveness. So this is not the best method. As all surgical procedure or percutaneous procedure, ECMO has some complications. I will not be long. I will just classify these in 4 groups. The blood complications, the neurological complications, there are always posturovascular complications or at the inferior limbs, and infections. When do we have to wean patients from ECMO? We must, of course, be sure of the hemodynamic stability. We must be sure that the mean arterial pressure is greater than 60 millimeters of mercury, and there are no present metabolic disturbances. The pulmonary function must be good, and the patients must tolerate an ECMO with 1 liter per minute. You should decrease the flow gradually to 60 to 2/3, then to 1/3 of the baseline until 1 liter for at least 1 day. And some criteria for the veno-venous ECMO. You have 2 methods: blood flow reduction method. In this case, you reduce just the blood flow, but without managing the quantity of oxygen. Or the second method, that you don't reduce the blood flow, you keep the blood flow its way, but you reduce just the gas flow. You can reduce fraction of derived oxygen from 100 to 21 if the patient keeps at a saturation of at least 92% and the PCO2 of at least 70%. And you should reduce the sweep gas to 1 liter. And then you do the off-sweep gas challenge, is a trial of sweep gas for at least 2 hours. If you want to go deeper in this topic, you can look at the ECMO Society, the Extracorporeal Life Support Organization. They organize a lot of meetings and they write a lot of papers. Another and the last concept I'd like to stress is that the ECMO is better managed in team. So we talk about ECMO team. Usually there is a cardiologist, a cardiac surgeon, an anesthesiologist, and also other specialists that can be a gynecologist or a nephrologist, depending on the situations. But they are mandatory to be, it is mandatory that a cardiac surgeon, a cardiologist, and an anesthesiologist take part to this team, and that the decisions are shared. The literature shows that the best results are achieved when decisions are taken together, and this is also better. It is better also for a medical legal point of view. Thank you very much.
Yes, a big thank you to you, Marco Piche, for sharing your such valuable insights with us today. If anyone has questions for Marco Piche, you are welcome to drop your questions in the chat or go ahead and unmute to ask him directly. Yes, Dr. Markovic, we extend our sincere appreciation for delivering your such an comprehensive and enlightening presentation with our
Thank
audience.
you very much.
Thank you
Thank you very much. It has been a
much.
pleasure. Thank you very much. It has been a pleasure to participate.
Yes, thank you so much. Yes, next, moving forward to the next presentation from Catalina Victoria Kenney from Cornwall, United States of America, to deliver her presentation on a rare case of an endocrinology emergency, extreme thyroid myxedema coma. Yes, Catalina, please start your presentation.
Hi, yes, I can go ahead and get started. And pull up my presentation here. I can share my screen. Let's see. Hi. Great. Go ahead and get started here. Presentation. Okay. Let's see. Okay. Can everyone see this? Great.
Yes, Catalina.
Okay, great. So the first one here is just gonna pull up this PowerPoint. Oh, hang on. You see if I can hit the slideshow. Here we go. Okay, so the first one is an interesting case about the life-threatening endocrinology emergency of pituitary apoplexy, particularly. So going into that, the presentation is incredibly rare. It was a 74-year-old male that had initially presented for GERD, hypertension, hyperlipidemia, alcohol use disorder, chronic kidney disease. They did have a history of pituitary macroadenoma in the past. They presented for generalized weakness and double vision for the last 4 days. Of note, while they were admitted to the hospital, the sodium was 133, so it was low. We had done a CT head, which showed redemonstration of the pituitary mass. We had ordered an IGF-1 just to see where we were at with the pituitary levels. And it actually came back at less than 33. ACTH was also less than 5, and DHEA was 18, LH of 0.3, FSH of 1. The testosterone was also less than 1. And the cortisol was less than 1, and prolactin was 1.6. Overall, this really showed that a lot of the levels were low in the pituitary function. So we had a very high suspicion of something abnormal in the pituitary gland itself. Our suspicion included pituitary apoplexy. So we initiated the patient on steroid supplementation and thyroid supplementation as well. We did also order an MRI to see if we can isolate a pituitary apoplexy, and it was actually confirmed on imaging. So we did note that the patient did eventually have this pituitary apoplexy, which is incredibly rare. They ended up going through an endonasal resection of the pituitary mass and was later discharged. Looking into the literature, it's so difficult to find this type of case. There's not really much in regards to literature on this or even incidents. However, we had noted it. The patient was successfully treated and managed, and they are currently on supplementation as well. Recognizing this, the patient initially presented with a headache. They had some visual changes. And roughly in 2/3 of patients with pituitary apoplexy, you're going to find this secondary adrenal insufficiency. And if you are able to recognize this condition, it's incredibly rare. Obviously, it helps improve patient outcomes. It improves overall effectiveness and treatment options for the patient. Definitely these are clues into how to recognize pituitary apoplexy and the successful management of that. Here you can see that on MRI as well. You can see obviously the enhancement there, indicating the pituitary apoplexy. And one of the best images is an MRI, so not just a CT, but going a bit further. The next one here is a rare case of another endocrinology emergency. It's called extreme thyroid. So initially, the patient presented with a hypothyroid picture. Overall, there was a 61-year-old male. He had a past medical history of autism, lymphedema, hypertension, Hashimoto's thyroiditis, and Castleman disease. He initially was found hypotensive, and we had done a bit of an infection workup for sepsis. The TSH was 0.08, free T4 was 0.4, and free T3 was less than 1.5. The patient was also hypoglycemic with a glucose of 40 and hypothermic as well at 35.5. The patient was bradycardic as well, with a heart rate of 59. Given all this, the patient was admitted to the ICU for hemodynamic instability. We had done a mixed edema score calculation as well, and it was measured to be around above 70. The TPO was ordered and returned at 49.0, and the TSH was 9.58, indicating Hashimoto's thyroiditis. The cortisol was 10.3, meaning that there was no adrenal insufficiency as well. There was a bit of an AKI of the kidneys, and the AC and ALT were elevated as well. We had started the patient on levothyroxine and cytomel for thyroid supplementation, and we're monitoring the T3 and T4 levels. However, throughout the stay, the patient did become hypotensive and had a stress dose of hydrocortisone that was provided. Overall, the patient continued to have hemodynamic instability, requiring multiple procedures as well. We did have extensive discussion with family, but this truly shows overall the poor prognosis of mixed edema coma and the complications. Unfortunately, the patient did not survive this complication. So it's an unfortunate outcome of mixed edema coma, but recognizing it is incredibly important in management as well. But the mortality rate is incredibly high in mixed edema coma. If you can recognize it, obviously, in these rare conditions, it's always better for outcomes. But unfortunately, in this case, the patient did die. Here's a little bit about the pathogenesis of mixed edema coma as well, showing the cardiovascular fluid balance and central nervous system effects overall. And lastly, this is a diagnosis of insulinoma in a patient that we had. So a little bit about insulinoma. It's incredibly rare. It's a hypoglycemia that's caused from a tumor in the pancreas, and it occurs in roughly 4 million people yearly. The few things that you want to get are glucose, insulin, C-peptide, proinsulin. Those are the few things to recognize the insulinoma. Here we have a 62-year-old female. She has a past medical history of seizures, recurrent hypoglycemia, and so we were suspicious of a possible insulinoma. She had a actual Whipple triad that was positive during her admission, so we noticed the low glucose, the diaphoresis, and then the improvement of symptoms with the dextrose supplementation. During a fasting state, we did order some hypoglycemia levels. The C-peptide was greater than 0.2. It was actually 5.9, and the repeat was 3.2. The beta hydroxy was 0.04, and the proinsulin was 1.9. DHEAS was 126. We had a suspicion of insulinoma at this time, and so we placed the patient on a D10 insulin drip as well. The patient's hypoglycemia agent screen was negative, also indicating an insulinoma picture. Overall, the diagnostic criteria for insulinoma includes looking at the insulin, looking at the C-peptide threshold, and the insulin C-peptide ratio of less than 1.0. And then obviously the absence of sulfonylurea in the plasma. So the patient through all those levels had met criteria for insulinoma. Although we were not able to particularly isolate a tumor at this time, we did go for an MRI of the patient and further management as well. If you can recognize the insulinoma and they meet the criteria for it, you can optimize them for surgical resection for treatment of insulinoma. So here you see the common criteria for insulinoma. It's incredibly rare, but insulin is greater than 3, proinsulin is greater than 5, beta hydroxy is less than 2.7, C-peptide is greater than 0.6, and you have to have a negative plasma sulfonylurea level. So those are the 3 cases. Overall, I will say incredibly rare cases. Obviously, the mainstay of treatment and management should always still be looking for the common conditions, but also keeping an eye for the differential of these rare conditions can help patient outcomes. So thank you so much for your time.
Yes, Catalina, thank you so much for addressing the interesting topic. If anyone has questions for Catalina, please post them in chat box or you can ask her directly to answer your questions. Yes, Catalina. Hope there were no questions from audience, and we once again extend our sincere appreciation to delivering such a comprehensive presentation.
Thank you so much.
Yes, dear esteemed participants, I would like to inform you that due to the busy schedules of some presenters, if you were unable to join today's sessions, so we sincerely appreciate your understanding in these regards, and I would like to extend our sincere gratitude for your presence and valuable contribution towards 13th World Conference on Cardiology and Endocrinology Diabetes Conference, which is held in Rome, Italy, as well as in virtually through Zoom sessions. Your thoughtful engagement, active participation, and commitments to advancing the fields of cardiology and diabetes were played a vital role in success of this conference. It was truly privileged to host such dynamic community of professionals, researchers, and thought leaders who are present here. We hope the sessions provided meaningful insights, encouraged collaboration, and inspired new ideas that will continue to impact your works and the broader healthcare community. Thank you once again for being part of this event, and we look forward to welcoming you again and again for our future conferences as we continue together for the foster global knowledge exchange and innovation. This is Sarah signing off from Innovine Scientific Meetings. We thank you everyone once again for your time and consideration towards our conference success.